Hemophilia requires a strong focus on access, equity, and awareness to ensure that all patients receive timely and effective treatment. Access to factor replacement therapy and specialized care centers remain limited in many regions, creating disparity in outcomes. Raising awareness among healthcare providers, patients, and public is critical for early diagnosis, proper management, and support. Innovations in hemophilia care like gene therapy, extended half-life treatments, and personalized medicine are transforming outcomes, offering patients greater freedom, fewer complications, and a future filled with new possibilities. Welcome to this fourth edition of the National Virtual Forum on Hemophilia Care, organized by Voice of Healthcare with associate partner Roche and supported by Priya Medical Technologies and SUT Patna Hospital. Join me in welcoming our speakers for the panel, Dr. Nita Radhakrishnan, additional professor NIUD, Department of Pediatric, Hematology, Oncology, Postgraduate Institute of Child Health, Seema Kapoor, Dr. Seema, Director Professor at Maulana Azad Medical College, Head Department of Medical Genetics. Dr. Seema would be joining us. Dr. Renu Saxena, Director Pathology and Lab Medicine and Head Hematopathology, Medanta, the Medicity Hospital. Welcome, Dr. Renu.
Thank you very much.
Dr. Shubha Phadke, Professor and Head of Department of Medical Genetics, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. She would also be joining us. So my first question goes to Dr. Nita. With prophylaxis using standard half-life factors concentrate now being adopted in some Indian centers, how has this shift impacted pediatric hemophilia management in your practice?
Yeah. So Dr. Manisha, prophylaxis, as you rightly said, is the standard of care for managing children and adults with hemophilia. So we follow the World Federation of Hemophilia guidelines, and this is the only treatment, the actual treatment that is mentioned is prophylaxis or replacement therapy. So the analogy for prophylaxis is that if somebody has a problem with, for example, a thyroid hormone is not being produced. So people who do not have, or people who suffer from hypothyroidism, take thyroxine tablet every day. Similarly, somebody does not have, the insulin is not being produced in your body, you are diabetic. So then you have to take regular insulin so that your sugar remains under control. So similarly, in hemophilia care, where factor 8 or factor 9 is not being produced properly, you have to take regular replacement therapy with factor 8 or factor 9, and which is otherwise called prophylaxis. But sadly, this is not accessible to the majority of people with hemophilia in our country, and even in other countries, if you see, this is the standard of care is followed only in high income countries mainly, because the factor concentrate is extremely expensive. Even in our country, very few states have access to prophylaxis as a treatment, and even when it is accessible only to few age groups, probably children less than 10 years or so. So any healthcare system where healthcare is supported by the government, or healthcare is subsidized heavily by government or other such treatment schemes, prophylaxis is still considered a luxury. But wherever we have access to standard half-life prophylaxis, we have observed that there is benefit definitely. So in trial settings and in Western countries, they've already shown us that when you reduce the bleeding, so we're not even thinking of life-threatening bleeds, just reducing musculoskeletal bleeds really impacts outcome. It reduces the target joint formation. It improves the disability. Does prevents disability. In fact, it people can resume their normal activity. Children can go to schools. Children can do activities at school like dancing or engage in sports without the fear of bleeding. They can adhere to physiotherapy better while they are on prophylaxis. So travel, school excursions, these are regular questions that we get, as in, can I go with my school? The school is going for an excursion. Can I send my son? So so these things can happen if we are on a good dose of prophylaxis. So even though we have access only for a small percentage, and we have observed in real world setting as well, that whenever we give them prophylaxis, their quality of life improves. And after childhood, when they are in colleges and in jobs as well, their adherence to job, their chance of getting a better job, because they are not disabled and they are able to perform better at workplace, is also proven when you are on prophylaxis.
So that is good to know that prophylaxis is improving the quality of life. Only thing is that the cost involved is, much more, and we have to make it more accessible and affordable. So my next question goes to Dr. Renu. With limited availability of advanced lab facilities, how effective are current diagnostics and monitoring methods like point of care testing in guiding early intervention?
Yeah, right. So this is a fact. There is a lot of you know difficulty in getting tests for hemostasis done. The basic test that is required is APTT, or activated partial thromboplastin time, along with the prothrombin time. These are two very simple tests which, even though can be done even manually, and yet there are very few labs, if we compare to the total labs in India, who actually do it. And part of the reason is because it requires stringent monitoring of the temperature, of the various techniques of clot detection by manual methods. And for the automated, you need continuous electrical supply. So, therefore, if we look at the number of hemophilia treatment centers, or in the remote areas where we might be able to pick up early hemophilia, they don't have access to such kind of tests. And so, as you very rightly said, today we are looking towards point of care testing. And even though there are quite a few point of care equipments for PT, APTT, which have come up in the recent years, we have very much our own developed in India POC kit, which has been developed in collaboration of National Institute of Immunohematology and the ICMR, who have brought out a test which can actually do PT, APTT both, and it's rapid and does not require high end electricity or equipment, and takes about 10 minutes to give you a result. And the results have been found to be very reliable, very sensitive, and it has a sensitivity of picking up to 5% of, like, if factor 8 is 5% of normal. Now, that is a limitation to my mind, because in severe hemophilia, we have less than 1% of normal. So maybe it may not be so useful in diagnosis of severe hemophilia, but may still be able to at least screen and pick up that, yeah, maybe this patient has low factor 8 and needs to be studied further. So that having been said, it might still be of use in monitoring hemophilics who are on therapy. Another POC, which is not as handy as this POC, which is actually on a lateral flow principle, which has been developed by Institute of Immunohematology, is a ROTEM. So ROTEM is an equipment which you can run at the side of the patient, but it requires electricity, definitely. And what you can do is, it may not be useful for diagnosis because it does not measure actual factor levels, but it can also be used for monitoring, because it can say whether the bleeding tendency has come down or has it gone up. So you can have a relative comparison with the baseline that may be there. So with the advent of these two POCs, I feel even in remote areas, we may be able to pick better than we used to pick up earlier. And that may definitely help us identify early hemophilics so that they can be managed properly.
Right, ma'am. So mild hemophilia needs to be picked up, and definitely monitoring can be, addressed with the help of
Yes.
POCT you just mentioned. That's so good to know. Dr. Nita, as gene therapy continues in clinical trial in India, how do you envision the future risk-benefit consideration for pediatric use in Indian healthcare setting?
Yes. So gene therapy, the good thing is that it is a reality, and it has been FDA approved, and there is more and more countries which have started their own indigenous research, looking at different techniques of doing it from what has been the technique which has been patented and pioneered. So it was 2011 when the first data came out, and since then I think almost like 14 years has passed, but it has not still replaced the current system because the technique is difficult and a lot of challenges related to it. Now, when you ask me about what are the challenges, or what I envision about the risk benefit the consideration for pediatric use, the current system uses AAV, or adeno associated vector is the virus is the vector, and this is used. And when this is used, the vector, when it is infused, the corrected genome is infused, it goes to the liver and it integrates with the liver genome, and it starts producing normal factor 8 or factor 9. Now, when that is done, in countries like ours, like where we have a higher infection prevalence and as a community because of crowding, etc., we would have been exposed to AAV during our childhood. So it is when we think about pediatric trials, we'll definitely need better strategies than what is currently there, because most of us would already have neutralizing antibodies against the AAV, which may reduce our chance of having a response, or maybe our body will not accept it because we have already been exposed to the virus earlier as an infection. Now we get it as a vector, you may not accept it at all. So that is one thing. Second is that although the data came out in 2011, the data on sustainability. So once you give this as a one time, so this is being thought of as a one time solution, and that is the biggest advantage of gene therapy, because it is a solution which is offering cure. Every parent when you counsel or when you disclose the diagnosis, what they want to know is it going to be cured? Is there a permanent solution to this? So that is the biggest advantage of gene therapy. But so far the data is not that mature. So it's although 2011, since then almost like 1.5 decades, but we don't know how the factor level will go on for the next 3 decades. Is it going to maintain the same way, or is it going to fall down? Do I have to have a repeat infusion after like 20 years? So that kind of data we do not know as yet. There are variants where the some reduction has been shown. There are variants where reduction has not been, it's not clinically significant. So it is too early to say that. And the third issue is the cost. And there again, we need to say that it's very heartening that there is work being done in India, especially CMC Vellore, and they have a different vector which is being used, and a different technique from what has been used in the US or UK. So these things should reduce the cost. One, it should make it more accessible to our patients with hemophilia, and it looks to be more promising. It should become that the cost would probably be in the range that is being offered by the government for rare disorders in the country. So it should be better. So that's something to hope for. And when we talk about gene therapy, we should also remember there are now a lot of
Your voice is breaking, Dr. Nita. Dr. Nita. Dr. Nita, can you hear me? I think there's some issue. Dr. Renu, I'll ask your question then. With potential availability of newer
Manisha,
therapies
can
like
you hear
gene
me?
therapy.
Hello?
Yes, yes, Dr. Nita, yes. If you want to add anything, please go ahead. It's a recorded
Hello?
session. We can edit it. Yes, I can hear you. Yes.
Can you hear me?
Yes. It's a recorded session, ma'am. If you want
Yeah,
to
so
add anything,
sorry.
please go ahead.
So shall I start from the question from the beginning, or shall I stop
No,
and
no.
No, no. There's no need. We could hear you. Like only last few minutes. You can repeat.
yeah, so I'll just leave it. Yeah. So that when we have many new products which are coming in, which is offering even subcutaneous injection once in a month, and there are new products now which you can even give probably once in 2 months. So a patient now who has to get like around 100 injections in a year now probably will come down to 6 injections in a year. So after that becomes a reality, we should still see which patients are still eligible or still would require gene therapy as a one-stop solution. So that part is also there with newer products, with better treatment modalities being available. Probably we will require gene therapy for a smaller subset of patients. So that is also to be kept in mind when we consider gene therapy for LMICs.
Right. So that is good to know that future is good and trials are, going on. And we know that if we don't have the neutralizing antibody, we can definitely look it up as a cure. And definitely we can have number of infusion and good quality of life. And this can be a future for hemophilic patients. So Dr. Renu, with the
Yeah.
potential availability of newer therapies in future, do you believe our current diagnostic framework and lab networks are equipped to assess treatment efficacies and monitor long-term outcome effectively for these newer therapies?
Yeah, that is a very relevant question because advances are happening so fast. We're getting newer therapies which are coming up, like we have emicizumab and we have like concizumab, all these newer anti uh, medications that we are getting. So the baseline, if you use the standard factor 8, the test that was used to be monitoring was a factor 8 assay. It would still remain a factor 8 assay, but the techniques are what may differ. So factor 8 assay normally is being done by the one-stage method or by the chromogenic method. By both techniques, one can measure these, and most of the labs today who are doing factor 8 assay, which by themselves are few, use one-stage assay, clotting assay. As we move on to newer therapies like emicizumab, um, it's been seen that if we use factor 8 assay by the standard one-stage method, it kind of is not appropriate for measuring factor 8. It gives much higher values than are actually there. So what is recommended is to use the chromogenic assay method for factor 8 assaying, especially using the bovine protein into it. So this is the method which is also recommended for emicizumab. So while we shift on to emicizumab, as in today's scenario, we would need to shift our technology from one stage assay to the chromogenic assay methodology. And similarly, we have the newer monoclonal antibodies which are coming, which are against the tissue factor pathway inhibitor. For them, we still need to work out which test would be the most appropriate. As of now, thrombin generation test is being advocated, but we have to still keep on looking further. One thing while monitoring the hemophilia patients is not just looking at the factor levels that are there, but also they may get development of factor 8 inhibitors. So we need to be geared to measuring the factor 8 inhibitors and quantitate them as well. So as I said, standard factor 8, we can use one stage method, we can use the modified Bethesda method by the Nijmegen modification. But for emicizumab, if we have to measure the antibody, the best way to use is to use chromogenic methods for factor 8 assays that we do as part of the Bethesda inhibitor detection. So that is something that a lot of labs are not doing right now. If we look at the number of patients who are on emicizumab is definitely much larger than the labs who are actually doing this method. So certainly, I think labs need to gear up to develop, to keep pace with what's happening on the clinical side so that they can monitor such patients in the lab itself. So with this, I'm hoping that hopefully in the next year or so, I think we'll probably have more labs who will be able to monitor these patients effectively.
Right, ma'am. This is need of the hour, as you said.
Yeah, yeah.
So, Dr. Nita, what are the most critical changes in terms of policy, funding, infrastructure you believe are needed to support the growth of multidisciplinary pediatric hemophilia care centers across India?
Yes. So hemophilia currently is being supported. Around 90 to 95% of patients are being supported by the Ministry of Health through what Government of India through what is called a blood cell, and blood cell takes care of hemophilia, thalassemia, and sickle cell. So we are getting treatment in almost all states of the country through that. So in every state, wherever a hemophilia treatment, so it is envisioned as an integrated hemophilia thalassemia centers because they have the similar requirement in terms of manpower, similar departments that are seeing it, etc., and chronic patients. So and these centers would get support for setting up a daycare. They would get support for some of the centers would get support for manpower, like in hemophilia's case, they would get support for physiotherapist, they would get support for a dedicated nurse, they may get support for a data manager, etc. And then they would get factor support. In most of the states, this factor is a procured look. For one state, it is procured centrally, and from that area, it is distributed to the different hemophilia treatment centers. So this is what is already established, and because of this and the funding, which is funding, which is allowing the state to purchase it, which is a combination of state and central government funding, the support is has actually revolutionized care. So even in the last 2 decades, if you see, the access to care has improved remarkably for these patients. So people who with hemophilia currently who are like 30 years or 35 years upwards, they would have a lot of joint deformities and joint issues. Their quality of life would be poor. Whereas if you see children who are less than 10 years who have been in the system getting access to all this, they'd have to travel lesser distances to get better treatment, get the standard of care. So that difference is still it's already palpable. Now, when you ask me what are the changes that are required, one is regarding a policy. You ask me if there is what are the changes in the policy. There is no current policy as such. The policy needs to be made. So a policy comes from center downwards. So there is a lot of request which has gone, and I think it's under consideration to develop a policy for uniform management of hemophilia. So diagnostics as well as therapy should be uniform. So, irrespective of which state you are, which socioeconomic sector you belong to, the treatment which is offered through the government sector should be similar. For every bleed, it should be uniform across the country. So, that is something which has been the slogan is one country, one treatment, I think. So that has been something which people are working on, and that would be really good to have a uniform treatment guideline which is there. Currently, we're following the World Federation guidelines, and very recently, there is a guidance document that has come from Hemophilia Federation of India with doctors who are affiliated with hemophilia care in the country. So, this kind of documents adapted for our region should be should come out as a policy that would really help in care, because then all this becomes sort of permanent, because the programs become when they are rolled out by the government, so then the manpower becomes more permanent, their salary structure, everything becomes more it's more sustainable. So chronic diseases such as this would require a dedicated team, and not a team which is like who shared between different programs. So that would really improve care in our country.
Right. So I also believe that one country, one treatment, and one team. So this should be the take-home message. So, Dr. Renu, how do you
Yeah.
see a centralized nationwide hemophilia registry with linked lab data and clinical outcomes contributing to research, quality, and health policy in India?
I think there is definitely a need today to have a kind of holistic registry As you said, having the patient profile, the lab tests into it, and the treatments and the follow-ups of the hemophilics or even bleeding disorders for that matter. So currently attempts are going on for registry. Hemophilic Federation of India has a kind of registry, but I think probably we need more inputs in that. Even though it is one of the largest registries that we have, and yet we need to have more inputs from a lot of places who have not yet been part of the registry. ICMR had started a registry as well, and that was supposed to be also, it's ongoing, but what is important for a registry is that all the stakeholders believe in it and share the patient details that they have. And once all the stakeholders are actually committed to it, we could get a real robust registry. And it is certainly the need of our, because then we will know exact prevalences, exact way the hemophilics behave in India, what is our treatment pattern in India, what are the responses. I think we really would benefit a lot from such a registry. So I hope in the future we will have more people interested in participating in it so that we have a holistic data from India.
Right. So registry is also required, I believe, and newer
Yes.
therapies coming into being. I think we can get so much out of it. The records, the health records, they can definitely guide us better. Right. I think Dr. Shobha is
Yeah.
there. Good evening, Dr. Shobha. Can you hear me?
Hello, good evening.
Good evening, ma'am. So I
Hi.
would take your questions. So, Dr. Shobha, in the context of variable access to treatment across India, how do you tailor education for families to ensure better home management and understanding of hemophilia?
Yeah, it's a challenge looking at the variability of educational status of the patients and families. But over last 30 years, what I have seen is a remarkable change, whether it's a treatment of thalassemia and hemophilia, screening for thalassemia, newborn screening. So education level of patients and parents, especially even the mothers, have increased so much. And now sometimes recently I noticed that they are not ready to even read pamphlets, and we can prepare lots of small videos, and people prefer education through YouTube videos. So these are the things which probably now, because in UP and many other states, government is taking care of the treatment financial aspects. So hemophilia societies can take up this challenge and increase access to the knowledge about treatment of hemophilia. So lot of audio visual aids, and in our state now people have really mapped all the patients, their age, weight, locations. So naturally the treatment plans can be individualized, as well as cost calculations become very easy. So for preparing a proposal for the government and finding cost effectiveness of the these treatments, now all these technological advances in communication as well as record keeping, website in Uttar Pradesh for their drug delivery and record keeping. So I think there are major changes, and this is facilitated. We have to use optimally and involve hemophilia societies, who now do not have much responsibility of arranging factors. So they can be more involved in the education. These are some of my thoughts.
Bilkul, yes, ma'am. I also believe that hemophilia societies, since they are working hard, they can be involved, especially with the newer therapies coming into being, and especially the prophylaxis, that can be given to the patient for better quality of life. So my next question would be, given the global advancements in gene therapy, how do you, as a clinician, view the balance between these emerging treatments and the importance of relying on already established evidence-based therapies that are currently available in India? Dr. Shobha, please unmute yourself, ma'am. I can't hear you. Dr. Shobha, you have to unmute yourself. Dr. Shobha?
Hello, can you hear me
Yes,
now?
yes. Now I
Uh-huh.
can hear you.
Okay. So this new, like all our aim since last 35 years was waiting for the gene therapy for thalassemia and hemophilia. And now it is there. It poses new dilemmas and challenges to the patients and to myself. If really I want to advise the patient what to do, whether who should go for gene therapy versus when the availability of long-term prophylactic therapies are easily available and maybe free of cost. So what should be done? It's a major challenge, and I think we need to have our internal discussions and some surveys, questionnaire based surveys amongst doctors as well as patients. I saw some such type of publications from various bodies, and we have to really think about who would be the advantage of gene therapy is cure, long term cure. But still, there is a fear of unknown, and we don't know the long term effects. While we have now enough studies for the drugs like imicizumab, and then with availability of these drugs, whether patients would like to take some risk involved with gene therapy and not. So, again, a lot of surveys are needed. What people and clinicians who are treating these patients are needed. So, I don't have a specific answer, but we have to really uh, uh, think and more as more data. One important thing is gene therapy is not easily available to us and our patients. So when till it becomes available, we have to be prepared in our mind who would be given gene therapy and versus the cost effectiveness of these long acting prophylactic therapies. So this is a really question which I have never thought over last 20, 30 years, that when gene therapy available, we would be wondering whether we should take gene therapy or not. So but this is real question because other equally effective therapies are available now. So maybe all of you may have some other thoughts on your mind, and maybe if something different, I would like to find out from what all you all people think.
I think this is the way, ma'am. We have to take, opinions from clinicians who are practicing, and then only we can, decide that what should be done, right? And my last question to you would be that from your experience, what models of community-based or hospital-linked care have effectively improved outcomes in children with hemophilia in resource-limited settings?
Yeah, resource limited settings. We kept on saying about resource limited settings, but I realized that we are no longer that resource limited. When and I want to myself convince that there are no such resource limitations. And government also has shown that if there is a will, there is a way, and they are supporting. So I think we should try for the best.
Right. Right, ma'am. I think this is a very good message to end on. We should try the best, and we are no longer resource limited. And if we have the prophylactic, therapies available versus the gene therapy, this time will definitely tell us that which one to use where. And definitely, this is going to happen because the trials are on, and the more data with the help of registries we get, more informed we will be. And with that, I end this, session, and I thank you all for joining me today in the session.
Excuse me, may I add something?
Yes, yes, yes,
Just
please, ma'am.
a word that now we have, because of registry of Seema as well as our state registries, we know so much details about our patients, age, weight, their disabilities, and we need to have brainstorming to find out cost effectiveness of real our guidelines. Whom to give prophylactic therapy, whom to give long acting factors, non-bypassing agents. So we should because all of us have experience of 3 decades or more, we should sit together and have our guidelines so that government can give budget accordingly, and it should not be arbitrary that somebody gets emicizumab, somebody gets this thing. So I think we should need sit together, make cost calculations and suggest government accordingly, and patients also exactly like this, less than 5 years, more than 5 years, with disability, without disability, lot of things can be considered and made into real guidelines.
Right, ma'am. I think the guidelines will shape as time passes by, and definitely we have the all the data supporting us. Thank you all for joining us today in this important discussion.
Thank you.
Thank you.